Hello, good evening friends. Today we will be seeing brain tumors. So, most common before starting, I would like to thank Chandana Shri Ma'am for sharing the wonderful notes with us. And these notes are very helpful for quick revision and are helpful for DNB-MS exams. The link for the notes is given in the description below. You can download it from there. So without any further delay, let's get started for the topic of brain tumors. So most common brain tumor are the metastatic tumor, which are 5 to 10 times more common than primary brain tumor. Three most common primary brain tumor of the brain in adults is the GBM, that is glioblastoma multiforme, other is meningioma, and the lastly astrocytoma. In children, it is medulloblastoma, astrocytoma, and GBM. In less than 2 years of age, it is again medulloblastoma, ependymoma, and low-grade glioma. So medulloblastoma is common in children and less than 2 years of age. Now we see the classification, that is the WHO classification 2016 of brain tumor. So firstly, it is diffuse astrocytic oligodendroglial tumor. They include astrocytoma or glioblastoma. Other astrocytic tumor is the pallocytic astrocytoma. Other gliomas are the choroid gliomas. Ependymal cell tumor are the ependymomas. Sorry for the delay. So others like neuronal mixed cell neuroglial tumor like the ganglioma, choroid plexus tumor like choroid plexus papilloma, pineal tumor like pineocytoma, embryonal tumor like medulloblastoma, cranial or paraspinal nerves tumor that is schwannoma or neurofibroma, meningiomas, mesenchymal tumor like hemangioma, chondromas, cellular tumors like craniopharyngioma, melanocytic tumor like meningeal melanoma, lymphomas that is DLBCL malt lymphoma, histiocytic that is Langerhans cell histiocytic tumor, germ cell tumor like teratoma germinoma, or metastatic tumor. Now classification depending on the cells of origin. So first from the neuroglia, that is the glial cells, that is the most common gliomas 50 to 60%, astrocytes which will be astrocytoma or GBM, oligodendrocytes that is oligodendroglioma, ependocytes that is ependymoma. Then neurons, that is ganglioneuroma or neuroblastoma. Primitive neuroectoderm, medulloblastoma, choroid cells, choroid plexus papilloma, arachnoidal fibroblast meningioma, endothelial cell hemangioma, primitive notochord remnant chordoma, pituitary cell adenoma, pineal parenchymal cell pineal cytoma, Schwann cell neuronoma, schwannoma, lymphocyte CNS lymphoma, primitive germ cell tumor like uh, or teratoma, melanocyte like melanoma. Now we'll see the hereditary syndrome associated with brain tumors, which are neurofibromatosis type 1 and type 2, von Hippel-Lindau's which has hemangiomas, NF will have neurofibromas, tuberous sclerosis has astrocytoma, Leigh-Fromeni will have gliomas, MEN1 will have pituitary adenoma schwannomas, retinoblastoma syndrome, Turcot syndrome will have GBM medulloblastoma and colorectal polyp, Werner syndrome will have meningioma, Cowden syndrome cerebellar gangliocytoma, and others like Gorlin and Muir-Torre syndrome. Now we see the primary brain tumors, which could be intraaxial or extraaxial. Intraaxial, which arise from within the brain parenchyma. They produce symptoms by three mechanisms, where the first is the tumor cell infiltrating along the nerve cell and the tracts, which causes seizures or fits, seizures or fits. Tumor cells grow as a mass, resulting in SOL, which will cause increased ICP, and due to compression will cause focal neurological deficit symptoms. These symptoms resolve when the tumor is resected. Then destruction of the adjacent neuroparenchyma symptoms, these symptoms do not improve after treatment. मतलब ट्यूमर निकालने के बाद भी वो ठीक नहीं हो रहा है. Then the extraaxial brain tumor, which are outside the brain parenchyma, these mainly compress the brain parenchyma, resulting in functional neurological deficit or seizure. Growth resulting in mass, that is SOL, which result in ICP, raised ICP causing symptom. When tumor is resected, the patient patient becomes in the normal state. Example is the meningioma. So mechanism of raised ICP in intracranial neoplasm is tumor mass, cerebral edema adjacent to the neoplasm, obstruction of CSF pathways, that is hydrocephalus, obstruction of the venous pathway, and the obstruction of CSF pathway occurs earlier in the posterior cranial fossa tumors. Now we see the clinical features. Symptoms of raised ICP, that will be headache, vomiting, mental status altered, Cushing's reflex. Mass shift will result in false localizing sign like abducens palsy, cranial nerve third palsy, hemiplegia involving the Carnohan's notch. Also we'll see the visual field effect. In children they will be having tense fontanelle and macrocephaly. Symptoms due to tumor itself, that is brain dysfunction, focal brain dysfunction, which will result in seizure, could be focal or generalized. Then functional neurological deficit in the form of hemiparesis or plagia, sensory loss, aphasia, cranial nerve palsy, visual field defect, personality changes. Pituitary pineal tumors will have endocrinal issues. Papilloma, choroid plexus papilloma will have CSF overproduction resulting in hydrocephalus. And symptoms based on tumor location, supratentorial frontal lobe will have seizure, intellectual and personality changes, motor disturbances, aphasia, anosmia. Temporal lobe will have personality changes, sensory aphasia, memory impairment. Parietal lobe will have apraxia and Gertzmann syndrome. Occipital lobe will have visual field defect, cortical blindness. Thalamus will have sensory disturbances. Posterior cranial fossa, they will have early CSF flow obstruction resulting in hydrocephalus, projectile vomiting, cranial nerve dysfunction, long track signs, and it is the most common brainstem tumor, that is astrocytoma. Now we go for investigation, that is CT, MRI with GD, that is contrast, diffusion weighted imaging, MR spectroscopy, angiography. Pathology of gliomas, that is WHO grading based on the grade of anaplasia. So grade 1 is the pilocytic astrocytoma, second is the oligodendroma, third is the anaplastic astrocytoma, fourth is the glioblastoma multiforme. Treatment of these are initially to decrease cerebral edema, we give dexamethasone steroid, surgical resection whenever feasible with adequate tissue sampling for the diagnosis. Neurological improvement is due to decrease in mass effect. Radiotherapy, which improves survival. Here we can also use stereotactic radiosurgery. We have 50 to 60 gray of radiation. Then chemotherapy, that is temozolomide for GBM. So this was all about brain tumors. Hope you have understood this topic. Please like, share and subscribe. Thank you for watching. Keep studying, keep growing and never give up. See you in next video.